Hi, welcome to Pathology Riddles. Today we will be discussing the topic of rheumatic fever. What is rheumatic fever? Rheumatic fever is an acute, immunologically mediated, multi-system inflammatory disease which occurs few weeks after a group A streptococcal pharyngitis or streptococcal skin infection. So the most commonly affected age group is of children between 5 to 15 years of age. Some patients are genetically susceptible to rheumatic fever. So incidence is about 3%. The mortality rate of rheumatic fever has decreased remarkably worldwide. It is because of improved sanitation and rapid diagnosis and treatment of streptococcal pharyngitis. So pathogenesis, basically all the damage is caused by host immune responses. The causative organism is group A streptococcal infection, which causes antigen formation usually in throat infections. Now there are after 2 to 3 weeks, the immunological response to this streptococcal M protein is what causes the damage. There are antibodies and CD4 plus T cells which cross react with your host protein. This antibody activates complement system. It recruits neutrophils and macrophages. Then the cytokine released due to stimulated T cells, it will lead to macrophage activation. Now these macrophages, which are within the Aschoff bodies, will damage the heart tissue. In heart, there is inflammation of all the three layers, that is epicardium, myocardium and endocardium. So this is called pancarditis. Pan means all of the layers are involved. Aschoff bodies are basically foci of the T lymphocytes and plasma cells and activated macrophages. These activated macrophages are called Anischikow cells. Now, what are Anischikow cells? These are abundant cytoplasm. There is central round to ovoid nuclei, which can be binucleate also. The chromatin condenses in a central slender wavy ribbon-like pattern. It will look like a caterpillar basically. Verrucae formation is there. Verrucae are basically vegetation of the size 1 to 2 millimeter, which are present on the necrotic foci along the lines of closure of the valve. Now the most commonly involved valve is of the left side. There will be fibrinoid necrosis within the cusps or the cords. It can lead to mitral stenosis. There will be neovascularization, fibrous thickening, subendocardial irregular thickening, also called McCallum plaques in the left atrium due to this regurgitant jets. And there will be aortic stenosis. So how to diagnose rheumatic heart disease? Basically, there are criteria called revised Jones criteria. There should be evidence that there was a previous streptococcal, group A streptococcal infection, along with two major or one major and two minor criteria. So the major criteria are migratory polyarthritis, that is basically joint pain of large joints, and it keeps like involving different joints at different times. Then there is pancarditis, as already mentioned, the inflammation of all three layers, that is myocarditis, pericarditis and endocarditis. All three layers, if they are inflamed, then it is called pancarditis. Subcutaneous nodules. These are the nodules which are present on the extensor surface of the extremities. Then there will be erythema marginatum. These are skin rash basically. And then Sydenham chorea, which is rapid involuntary movements. It is a neurological disorder. The minor criteria include fever, arthralgia, increased ESR and CRP, that is increased erythrocyte sedimentation rate and C-reactive protein. These are basically markers of any kind of inflammation which is going on inside the body. And then there is increase of ASO titer. Now coming to the chronic RST, this is an entity in which mitral valve and less commonly aortic valve show leaflet thickening. There is commissural fusion, shortening and thickening and fusion of this tendinous cord. Microscopically, there will be organization of acute inflammation. So as already mentioned, there will be neutrophil and macrophages coming. And after this inflammation has subsided a little bit, there will be post-inflammatory neovascularization, that is new vessel formation. There will be transmural fibrosis. Transmural means complete thickening, thickness of the cardiac muscle. It will be fibrosed. This will obliterate the leaflet architecture. Then Aschoff bodies are rarely seen in surgical specimens or autopsy. In rheumatic mitral stenosis, calcification, fibrous bridging along with valvular commissures creates a fish mouth stenosis. So the stenosis, because the ends of the valves are getting fibrosed and sticking together, so the opening looks like a fish mouth. When there is tight mitral stenosis, then because this mitral stenosis, the left atrium dilates because it cannot push all the blood through that mitral valve into the left ventricle. So this can cause mural thrombi. These thrombi have propensity to emboli. So they will just break off and go to different parts of the body. There might be congestive changes in lung and right ventricular hypertrophy. Now, because of back pressure, your lung can get affected. The blood which is supposed to be transported from the lung to the heart, it cannot reach there because there is so much of back pressure. So there will be congestive changes and there will be right ventricular hypertrophy. Coming to rheumatic heart disease consequences, the first consequence is cardiac murmur. So the normal heart sounds are lub and dub. Once the valve becomes stenosed or floppy, then the blood passing through such valves will make an extra sound that is called cardiac murmur. And depending on how the valve is, the murmurs will come at the different times. Now, there can be cardiac hypertrophy whenever there is a stenosed valve like aortic valve, then left ventricle has to make more contraction to push the blood through it. Now, to help with the contraction, there will be cardiac hypertrophy, that is the muscle mass of the heart will increase. Then if more pooling of the blood is there in the ventricles, then it has to accommodate more blood. For that, cardiac dilatation has to happen. Then if all the compensatory mechanisms which are being done by heart fails, so it will lead to congestive heart failure. Arrhythmias with arterial fibrillation, if the conduction pathway or bundle of His is damaged, then there can be such consequences, arrhythmias with arterial fibrillation. Then, as discussed earlier, there can be mitral stenosis with thromboembolism. So, if the mitral stenosis is there, there will be more pooling of the blood in atrium. That will lead to thrombi formation. Now, this thrombi can detach and go to different parts of the body, leading to thromboembolism. Then infective endocarditis, basically the valves are damaged, so they give a nidus for this bacterial infection to go and attach and form vegetations. So that will lead to infective endocarditis or bacterial endocarditis. So these were the consequences of rheumatic heart disease. Hopefully you understood the topic. If you have any questions, you can write in the comments below. Please do share and subscribe. Till we meet the next time, this is Dr. Bismay signing out.